Hello everyone, welcome back to yet another lecture series in overview and integration of cellular metabolism. Today's class is on fructose metabolism and its associated disorders. We will be covering the following concepts. We will be covering the pathway of fructose metabolism, we will be covering facts about polyol or sorbitol pathway. We will see how fructose metabolism can lead to hyperlipidemia, how fructose plays a role in fertility or infertility, what is essential fructosuria, and what is hereditary fructose intolerance. All these concepts will be covered one by one. Now, considering fructose, it is a ketohexose. So, glucose, in the last class I showed you how glucose and galactose were epimers. In this case, the structure of glucose and fructose, again if you count the number of carbon atoms, they are same C6H12O6. How it varies? There is an aldehyde group in glucose, but there is a keto group in the second carbon of fructose, right. So, this is how fructose differentiate from glucose, just to have the fundamental concept. Now, regarding, so this is a ketohexose, right, 1, 2, 3, 4, 5 and 6 carbon atoms. This is an aldohexose due to present of aldehyde group glucose, and this is a ketohexose, right. So, ketohexose, where it is present mainly in fruit juices and honey, right, all the sweet products they contain fructose. But the chief dietary source is the sugar that we are taking everywhere with the tea, with any bread toast or any food, right, sugar. Sucrose is hydrolyzed by the intestine with the enzyme sucrase, okay, and fructose is absorbed by facilitated transport and is taken up by portal blood to the liver, where it is mainly converted to glucose. So, these are few facts which I think you already know by now, because we have covered it in the class of glucose, I mean carbohydrate transport, right. And fructose is easily metabolized and it is a very good source of energy. These are few facts. Let us discuss about fructose and then we will be delving deep into the ones that needs explanation. So, it is easily metabolized and is a good source of energy. We will see how it is easily metabolized, much easier than glucose. Seminal fluid is rich in fructose and sperms uses fructose as a source of energy, right. In diabetics, fructose metabolism through sorbitol pathway may lead to the formation of cataract. Do not worry, I will be explaining everything, just keep these things in mind. So, first things first, the phosphorylation of fructose. This is the first step in fructose metabolism. So, fructose can be phosphorylated in two ways. In the last class you learnt about the enzyme galactokinase that was converting galactose to, you must be knowing, I will not answer, it is for you to answer. Fructokinase is an enzyme that converts or phosphorylates fructose in the first position to convert it to fructose 1-phosphate. Remember, hexokinase is an enzyme that can also act on all hexoses. So, fructose, glucose, galactose, hexokinase can act on all hexoses and it generally preferentially phosphorylates in the 6th position, right. But the affinity for hexokinase to fructose is very low. We will be discussing it again. So, fructose always prefers to be phosphorylated by fructokinase as compared to hexokinase. So, fructokinase, where this enzyme is mainly present, liver, kidney, muscle and small intestine. Very important, fructokinase is not dependent on insulin, but hexokinase is dependent. This is a fundamental difference, and affinity of hexokinase enzyme for fructose is very low. So, this reaction where fructose is getting converted to fructose 6-phosphate. So, if till now, if I ask you or if you are being asked about how fructose can go into carbohydrate metabolism, you can easily use your knowledge from previous classes that okay, hexokinase can act on fructose to form fructose 6-phosphate, and fructose 6-phosphate is a product of glycolysis, right. So, glucose 6-phosphate to fructose 6-phosphate by phosphohexoisomerase, and this is basically EM pathway, Enden-Meyer pathway is glycolysis, right. But this does not happen often. Why? Because hexokinase never or almost does not want to act on fructose. So, what act on fructose? Fructokinase acts, okay. So, fructokinase acts on fructose to form fructose 1 phosphate. So, phosphorylation has happened in the first position. Okay. If you look at the structure, as I told you, it is easier to understand, but you may choose to ignore the structure. It is the next enzyme that is extremely important. So, what it is doing, remember in glycolysis there was an enzyme aldolase A or aldolase that was breaking down a 6 carbon into 2 3 carbon compounds. It was breaking fructose 1,6 bisphosphate to glyceraldehyde 3 phosphate and dihydroxyacetone phosphate. If you are finding difficulty in remembering, go back to as early as week 2, then you can tackle the lecture on glycolysis. Over there you will be able to see, right, week 1, 4th lecture was glycolysis, right. So, in glycolysis we discussed the aldolase A enzyme. Over here aldolase B, it is an isoenzyme, right, an enzyme that is present in different part of the body but exerting a similar function known as isoenzyme. So, what aldolase B is doing? Aldolase B is breaking down a 6 carbon compound fructose 6C to 2 3 carbon compounds, they are glyceraldehyde. Okay, it is glyceraldehyde and dihydroxyacetone phosphate, right, glyceraldehyde and dihydroxyacetone phosphate. So, this phosphate group is with this one dihydroxyacetone phosphate, and this from here it is getting cleaved in the form of glyceraldehyde. Okay. This glyceraldehyde can be phosphorylated by a kinase enzyme, since it is a tricarbon or 3 carbon carbohydrate, it is a triose, just like glucose is a hexose, erythrose is a 4 carbon compound, right, pseudoheptulose is a 7 carbon compound. So, this is a triose. Okay. It is getting converted by triose kinase to glyceraldehyde 3 phosphate. Glyceraldehyde 3 phosphate, dihydroxyacetone phosphate, you already know what are their fates, they all continue to glycolysis, right, or even they can go in the reverse phase in the when depending on the need, if we need to store glucose, they can also be utilized in the formation of they can also be utilized by other pathways to form glucose, whether by glycolysis or by gluconeogenesis. When energy is required, they are diverting into glycolysis. When we need glucose, they are diverted into the gluconeogenetic pathway. We will be looking into that, but the important message over here is the enzyme aldolase B is converting the fructose 1 phosphate to glyceraldehyde and dihydroxyacetone phosphate, and this glyceraldehyde is converted to its phosphate form by the enzyme triose kinase. So, if we look at this thing in an nutshell, you see fructokinase, it is converting fructose to fructose 1 phosphate, and it is getting converted by aldolase B to glyceraldehyde and dihydroxyacetone phosphate, and this dihydroxyacetone phosphate and glyceraldehyde 3 phosphate can actually go in this direction. Whenever you see pyruvate and lactate, it is glycolysis, right, glycolysis, or they can be acted upon by other enzymes where the 2 3 carbons, these are 3 carbons, they are getting converted to 6 carbon, and ultimately the reversal of glycolysis is happening, and this is neoglucogenesis or gluconeogenesis. Okay, neoglucogenesis, right. So, fructose can be the fructose can enter carbohydrate metabolism, and they can be diverted into glycolysis or gluconeogenesis depending on the requirement. You should also note, we will also be discussing that dihydroxyacetone phosphate can be diverted to glycerol pathway, and ultimately it is to the production of lipids. We will be discussing that, right. But one fate is TCA cycle and glycolysis leading to the formation of energy, and another is formation of glucose. This is the direct pathway of fructose metabolism. So, remember three important enzymes rather, fructokinase, aldolase B, and this is basically triose kinase. Anywhere glyceraldehyde, if it is the source, it can be converted to its phosphate by triose kinase. So, this is the most important enzyme, aldolase B. This is also important. Why? We will see very soon. So, now let us deal with sorbitol or polyol pathway. So, what is sorbitol or polyol pathway? This pathway deals with production of fructose from glucose, that is transformation of glucose to fructose via sorbitol. Do you know any situation where the body has excess glucose? Of course, in the disease diabetes mellitus, we will be discussing very soon. So, what happens in that disease? There is excess amount of glucose in uncontrolled diabetes mellitus, and that leads to an excess activity of these enzymes, that is aldose reductase and sorbitol dehydrogenase. Mind it, glucose, in the previous lecture I told you aldose reductase enzyme actually converts galactose to its alcohol dalcitol or galaxitol. The alcohol form of glucose is actually sorbitol. The alcohol form of fructose is also sorbitol. Okay. So, in presence of NADPH derived from HMP shunt, aldose reductase reduces glucose to sorbitol. What is the fate of sorbitol? This sorbitol ultimately is acted upon by sorbitol dehydrogenase to form fructose. Okay. Just know this, in diabetes glucose can be converted to fructose by the sorbitol or polyol pathway, right. So, what is the problem? You see, in uncontrolled diabetes, significant quantities of glucose can infiltrate the cells that are insulin independent, right. This leads to a problem where the intracellular glucose levels increase, right, and in specific organs that can lead to a huge problem, because specifically the organs like lens, retina, nerve cells, kidney, mind it, these are the organs that faces the maximum brunt of the disease, that is diabetes mellitus. These 4 organs, the eye, the lens, the nerves and the kidney. Eye is actually in the lens is actually in the eye only, right. So, they have got high aldose reductase activity and adequate NADPH. So, what happens? All these glucose are converted to sorbitol, but these, once it is converted to sorbitol, in diabetes these cells sorbitol dehydrogenase is either inactive or absent, right, because if there is a finite amount by which sorbitol dehydrogenase can convert sorbitol to fructose, but if excess amount of sorbitol is being produced, this enzyme will not be able to cope up, right, and it has been seen there is down regulation of sorbitol dehydrogenase in these cells, especially in lens, retina, nerve cell and kidney. All other cells do have adequate amount of sorbitol dehydrogenase activity. So, they can actually tackle excess sorbitol and they can convert it into fructose, and then fructose can be utilized for energy. But in these cells fructose cannot be converted, fructose cannot be produced because sorbitol dehydrogenase is low. So, what happens? Excess amount of sorbitol will be deposited, and just like the mechanism by which cataract was being produced in galactosemia, this sorbitol is hydrophilic in nature, it will imbibe water molecules and all those cells of those organs will swell up. So, be it nerve, be it kidney, be it eye, be it retina, everything will have the same problem of osmotic swelling, and that will lead to a hell lot of complications. So, there will be retinopathy, eye damage, there will be cerebral edema, there will be nephropathy, there will be neuropathy, there will be diabetic foot, the multiple paradigm or the plethora of symptoms is due to this one culprit, that is excess sorbitol accumulation in these cells in uncontrolled diabetes because of the hamper of the polyol pathways. Normally in polyol pathway glucose can be converted to fructose, it is good for our body. If this enzyme is deficient, there will be excess amount of sorbitol, and sorbitol will lead to all these problems, right. Now, there is a dictum that is, or often the question is found that fructose is more harmful than glucose. Why? Because fructose actually bypasses the rate limiting steps of glycolysis. So, what is a rate limiting step? Mind it, our body can control what is the amount of metabolic steps that are needed. It has already been discussed. So, the process of glycolysis is done by the first 2 steps, either hexokinase step and most importantly by the phosphofructokinase step. Those 2 are irreversible reactions. You can see Fructose actually bypasses those two important steps and it directly enters glycolysis in the form of glyceraldehyde 3-phosphate and dihydroxyacetone phosphate. Alright. So, this first step of hexokinase and the second step of phosphofructokinase, they are bypassed. So, if the body tries to regulate, or if my body now does not need any glycolysis, we do not need any anabolism from glucose, we need glucose for other storage functions. So, what is happening? Fructose, if we are taking excess in form of raw sugar, this whole step is bypassed and we are adding needless calories to our body, and ultimately this will lead to excess production of acetyl coenzyme A via TCA cycle, and that acetyl coenzyme A will be used in fatty acid synthesis, right. Also synthesis of cholesterol and all other culprit. As I told you, the minor pathway in which fructose is entering into the glycolysis by bypassing the hexokinase pathway by directly forming glucose 6-phosphate usually does not happen, right. Even if it happens, it is still bypassing the one regulating step, that is hexokinase. But if it does not consider this step because it is very rare, why I told you hexokinase has got very low affinity for fructose. It is mainly acted upon by the enzyme fructokinase. This is a fructokinase enzyme, and fructose directly enters into the glycolytic pathway, and it is contributing to the excess unwanted calories of the body. Next, excess fructose. Over everywhere we see raw sugar. Every dietitian will prescribe you, or every doctor, anybody who knows about diet, and now we will also know that raw sugar is harmful for our body. Why? These are the reasons, because it will lead to excess calorie, and now it is also lead to an alteration in lipid profile. Let us see how fructose consumption leads to insulin independent action of several important lipogenic enzymes. It means what? Those lipogenic enzymes means that are helping in synthesis of various lipid particles that are being upregulated. So, there will be more and more synthesis of lipids. It has been seen that diets in high fructose are leading to hypertriglyceridemia (TG) in population. These are all population based studies, and it has been seen that a diet that is high in fructose or raw sugar, sucrose, again it is getting converted to fructose, those cases or those subjects do have high TG on measuring in lipid profile, and that is again very harmful and leads to a lot of cardiovascular disorder. If we want to know the biochemical pathway, it is right in front of you, where dihydroxyacetone phosphate and glyceraldehyde is actually diverted to formation of glycerol 3-phosphate, and as already told you, excess fructose is leading to the formation of acetyl CoA and it is leading to the formation of fatty acid. So, we all know fatty acid and glycerol is the key component or unit by which a lipid is produced. So, triglyceride, variorodalcyl lipoprotein, TG, all are formed in excess only and only due to high fructose in diet, right. Mind it, for production of fat we need both fatty acid and glycerol. Excess fatty acid, why it is produced? It is because of excess glycolytic activity, excess TCA cycle, excess acetyl coenzyme A. So, that acetyl coenzyme A will be diverted to synthesis of fatty acid. You will learn in detail how fatty acid is synthesized in the upcoming lectures when you are dealing with lipid metabolism. For now, you know that it is leading to excess production of fatty acid, that is acetyl coenzyme A. It is also increased, and glycerol production is also increased because of increased glycerol 3-phosphate by the enzyme glycerol kinase, right, and dihydroxyglycerol 3-phosphate dehydrogenase. These two enzymes actually act on glyceraldehyde and DHAP to form glycerol 3-phosphate. Glycerol 3-phosphate along with fatty acid, they esterify together and ultimately leads to the formation of triglyceride, and that is a culprit why excess fructose in diet leads to hypertriglyceridemia. It will also help you to answer the justified type of question. Now, something regarding fructose and infertility or fertility. See, seminal fluid actually have got large concentration of fructose because it is important for survival of sperm. Okay, seminal vesicle discharge fructose. So, what happens if there is some disease, that is azoospermia. Okay. Azoospermia is a disease in which there is a dead sperm or quality of sperm is hampered. It is a disorder of males and which is a major cause of infertility, right. So, during azoospermia we do a test for any anatomical defect. Anatomical defect is defect in any duct or any pipeline for that matter. So, what happens over there, you see seminal vesicle. So, what if there is a block and seminal vesicle sperms are not being delivered, there is no sperm, right. So, what happens, since we know seminal vesicle secretes fructose, okay. So, with one simple test we can have an idea whether the block, if suppose there is a kink or block in the pipeline, then sperms cannot reach, right. So, if the azoospermia is caused by duct obstruction, right, fructose concentration, I mean the semen fructose content is estimated. Okay. So, how we can get an idea whether the block is present above or below? See, if fructose is present, the block is located above. So, if there is block above the seminal vesicle, the fructose is actually coming from seminal vesicle, right. So, there might be no sperm in semen, but there will be excess quantity of fructose, right. But what if the block is in here? It means the sperms are reaching, but they are not getting out. So, the block is located after seminal vesicle. If the block is located after the seminal vesicle, fructose will not be found, because over here fructose cannot reach the semen. You get my point? Again, a very easy illustration. Suppose you are getting a black colored water from this pipeline, okay, and ultimately we are getting grey colored water, because white color is coming from here, black color is coming from here, grey color is coming from here, right. What if the block is above? If the block is over here, then what will happen? Black water will be coming from here and ultimately we will be getting grey colored water. What if the block is below? It means there will be no black colored water, right. Mind it, there are multiple other ducts by which other contents of semen are secreted into the ejaculatory tract, but this simple test can tell us whether the block is above the seminal vesicle, in which there will be fructose which is secreted from seminal vesicle, or there is no fructose if the block is below the seminal vesicle. This is for just multiple choice question. You just remember, if block is located after seminal vesicle, the fructose will be absent. If the block is located above seminal vesicle, will contain fructose in cases of azoospermia, right. But needless to say, we need fructose for healthy sperms, okay, and that will treat infertility, or that is one major cause of infertility. Anyway, now coming to fructose metabolism. Fructose metabolism defect leads to inborn errors. So, let us see what are the errors. The major error with which we should be concerned is actually hereditary fructose intolerance, or HFI, okay, and this is due to deficiency of aldolase B. The incidence is 1 in 20,000 to 30,000. So, what is the problem? Just like the concept of galactosemia, over here, since aldolase B is deficient, fructose 1-phosphate is accumulated, it will inhibit glycolysis and gluconeogenesis, it will get accumulated in multiple cell, and that will lead to all the symptoms, okay. Just relate with, if you have understood galactosemia, you will easily understand hereditary fructose intolerance. So, fructose 1-phosphate accumulation inhibits glycogen phosphorylase and glycogenolysis is inhibited. This results in glycogen accumulation in the liver, just like galactosemia, okay. So, glycogen, if it cannot be broken down, glycogen is accumulated in the liver and it accumulates and lead to the formation of hypoglycemia as well as hepatomegaly. The children the baby with hereditary fructose intolerance cannot thrive. Okay, so there is vomiting, loss of appetite, hepatomegaly and jaundice. The reasons are same as galactosemia. Okay, if so, this is the beauty of metabolism. If you understand one topic, one concept, the next concept will be very clear. And since again due to excess accumulation of glycogen and fructose 1-phosphate, the cells swell up due to osmotic imbalance. The liver cells, since fructose metabolism preliminary happens in liver cells are again at a dysfunction, and that if it is in severe grade, it will also lead to cirrhosis and death, that is permanent damage of the liver. Now, you see galactosemia, since it is coming from mother's milk, it exhibits it right at birth, right, but generally fructose, since the main dietary source is sucrose, it expresses when weaning or artificial feeding is started to the baby, which generally occurs at 6 months of age. So, what is the treatment? The treatment is elimination of all sources of fructose from diet. We need to eliminate raw sugar and then there will be no problem. Okay. So, fructose is excreted in urine, and since I told you excess fructose will get accumulated because fructose 1-phosphate is excessively formed, and after some time there will be no need of conversion of fructose to fructose 1-phosphate. So, there will be fructose in urine, that is known as fructosuria, and this fructose is a reducing ketohexose. So, this will give positive Benedict's test, which is a test for reducing substances. It will give positive Selivanov's test, which is a test for ketose, monosaccharides, right, monosaccharide but ketose sugar. Now, this is all about hereditary fructose intolerance. What do we need to know about essential fructosuria? It is a minor disease where fructokinase enzyme is deficient, fructose cannot be converted to fructose 1-phosphate, excretion of fructose. So, since fructose is excess, it will be excreted in urine, right. That is the only problem. Mind it, fructose will not be accumulated. Just like galactosemia, hereditary fructose intolerance also leads to cataract, right. So, in this case there will be no treatment is not indicated. However, since there is fructosuria, there will be positive Benedict's and Selivanov's test. So, hereditary fructose intolerance as well as galactosemia both are reason for congenital cataracts. Mind it, congenital cataract, same reason, aldose reductase, excess sorbitol, excess accumulation in the lens and all the problems, right. So, to summarize, you see essential fructosuria is formed due to deficiency of fructokinase enzyme, hereditary fructose intolerance is due to deficiency of aldolase B. Fructose can bypass the rate limiting steps of glycolysis and it can be converted to dihydroxyacetone phosphate and glyceraldehyde 3-phosphate, and it can enter into the glycolysis and TCA cycle, or it can be used in gluconeogenesis. So, these are the concepts that have been covered. This is basically a summary slide of concepts covered, and these are the references, and I thank you for your attention. That will be it for today. Bye.